Hello, everyone, and welcome to today's webinar, New Guidance for Investigation of Vitamin B12 Deficiency, Considerations for Transitioning to Appropriate Testing. I am Cassie Soltman of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Abbott. To learn more, visit corelaboratory.abbott. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. Also, if you experience any technical issues, you can utilize this Q&A box and we will assist you directly. I'd like to now welcome our speaker, Professor Dominic Harrington, Chief Scientific Officer at Synnovis. Professor Harrington, you may now begin your presentation.
Hello, I'm delighted to have the opportunity to present a few slides on the laboratory assessment of vitamin B12 status. The emphasis of my talk will be on how we use the biomarkers and how we interpret them. But before we do that, I thought it might be worth just spending a few moments thinking about vitamin B12 and why it's so important for our health. Vitamin B12 is unusual for many reasons. Not only is it the largest of the 13 known vitamins, it's also one of the largest non-polymeric biomolecules that's found in nature. B12 is also unique in it's the only known compound in nature to have a cobalt-carbon bond. This cobalt atom is absolutely critical to the structure of vitamin B12. The cobalt atom is held in place by 4 equatorial nitrogen atoms. The 5th coordination site is the same for all the vitamin B12 molecules, but it's the 6th coordination site that confers metabolic utility. If there is a methyl group, this is known as methylcobalamin, and this is indicated in the figure by the R group. Or if we have a deoxyadenylyl group, this is known as deoxyadenylyl-cobalamin. We have 2 vitamin B12 dependent enzymes in our body, methionine synthase and methyl-molynol coenzyme A mutase. Methionine synthase requires methylcobalamin, and methyl-molynol coenzyme A mutase requires adenylyl-cobalamin. Another reason that B12 is so interesting is because the synthesis of the vitamin is restricted to only certain bacterial strains, so it can only be made by some prokaryotic life. There are 2 different pathways for the synthesis, but full de novo biosynthesis requires a sequence of about 30 enzyme-catalyzed reactions. This is quite labor intensive, so many organisms try to avoid making the vitamin and would prefer to obtain it from somewhere else. Plants have no metabolic requirement for B12. They have no mechanism for its production, and they are unable to store it. We, however, have a dependency on exogenous sources of B12, which in most cases means that we need to obtain it from the diet. Now, vitamin B12 deficiency can be quite difficult to diagnose, and there are a number of reasons for this. One of the reasons is that the signs and symptoms of deficiency are often vague and often non-specific. Healthcare providers tend to look for anemia, but actually about 20% of B12 deficient people don't have anemia at all. So deficiency can masquerade as a multitude of different illnesses. But the prompt diagnosis and treatment of B12 deficiency is important because it protects against megaplastic anemia, potentially irreversible neuropathy, and some neuropsychiatric changes. There are a number of reasons why any one of us on this call may develop B12 deficiency. We may choose to follow a vegetarian or vegan diet. These diets are very low in B12, and it would be unlikely to meet our metabolic requirements, and you would need to take a replacement supplement. You may have impaired gastric absorption, for example, if you have the autoimmune disease pernicious anemia. As we all get older, it becomes increasingly more difficult to undertake efficient gastric absorption of B12. Most B12 is absorbed in the ileal. If you have had an ileal resection, for example in Crohn's disease, you will have impaired intestinal absorption. Good pancreatic function is also critical for efficient absorption of B12. There are a number of congenital disorders that may confer a deficient state. During pregnancy, there is an increased risk of deficiency because you have an increased requirement for the vitamin. Or there are a number of acquired drug effects, for example, in nitrous oxide abuse. Now, B12 deficiency is not rare. In the United Kingdom, which is where I happen to work, about 5% of people over the age of 65 to 74 will be deficient. The incidence of deficiency increases with age and is more than 10% in people who are older than 75. But I've already mentioned that the signs and symptoms of B12 deficiency can be difficult to recognize. Well, actually, the laboratory assessment of B12 status is also no easy task. And it's long been known that even patients with pernicious anemia, who could go on to develop quite severe deficient states, sometimes have to wait several years for a diagnosis of B12 deficiency. This has a huge impact on the quality of their lives. It may prevent them from working. If you are a young person with B12 deficiency, it may prevent you from going to school and affect your future prospects. So some of us may think that this is an unexpected challenge because laboratories have been determining B12 status using a serum B12 assay for more than 50 years. But in some situations, when serum B12 measurement is used in isolation, the chances of correctly diagnosing B12 status is only marginally superior to flipping a coin, heads for deficient, tails for replete. This causes a delayed diagnosis for the patient. But in addition to that, it causes an unnecessary burden on the wider healthcare system because the patient ends up having multiple unnecessary consultations, and there will be repeat unnecessary laboratory tests. With all the vitamins, once they were discovered, the instinct was to measure the vitamin in blood to determine status, and this works quite well for some vitamins. The first serum B12 assay arrived in 1950, and it was an excellent microbiological assay, but it was quite manual. What we have seen in the last 75 years is a series of technology innovations which have led us to today's highly automated competitive protein binding assays. At the same time, we have seen, quite rightly, an increase on quality. So now we're in a position where we can generate a highly automated serum B12 result in a high quality environment. But have we spent sufficient time thinking about the utility of the test itself? Well, I hope so, because we perform a lot of them. In the National Health Service in England, there's enormous variation in the number of serum B12 tests ordered by different regions annually. In some regions, they order up to 120 serum B12 tests per 1,000 people in the population each year. But even in the areas that order far fewer tests, it's still one of the most commonly requested pathology tests. But how many people ordering that test actually know what is being measured and what the result is telling them? How many people performing the test for the requester understand the limitations of the analysis they are performing? Now, interpreting a serum B12 assay result within a laboratory is quite simple, isn't it? We have a reference interval, and if the concentration of serum B12 is below the lower limit, we classify it as deficient. And if the results are above this, we classify it as replete or high. So we say that that is fine. So if I was concerned about my B12 status, and an aliquot of my sample was sent to all the laboratories in the United Kingdom performing the serum B12 test, how confident would I be in the diagnosis that I received? Well, I wouldn't be very confident, because depending on the laboratory that performs my test, I could be told that I am deficient, so I have a low concentration, that it's indeterminate, that is normal, or that is high. I'd be very confused. Now, several things may strike you when you look at this figure. One thing that I hope you can see is that the harmonization between the different platforms is quite poor. So partly the result you get will be dependent on the assay that's being used rather than the actual concentration of B12 in your serum. But actually, even if these data points were all the same color, even if they were all green, I would still have some questions. And this is because we know that the serum B12 test, like any biomarker, has some limitations. So one of the limitations of the serum B12 assay is that it's measuring abundance. It's telling you how much is there. This doesn't tell you what's going on in the tissues. It doesn't give you an indication of function. Many people may not realize that a serum B12 assay is actually reporting a total of 2 different types of B12. The most abundant form is the B12 that's bound to haptocorin. Haptocorin circulates in an almost fully saturated form. It's saturated with B12, but it's also saturated with B12 analogues. And as far as we know, haptocorin does not contribute to vitamin B12 status. Transcobalamin is another B12 binding protein that circulates in a nearly unsaturated form, mainly unsaturated form, and it binds any freshly absorbed B12 from the diet. So once the B12 binds to the transcobalamin, this is called holotranscobalamin. And all cells that require B12 to function have receptors for holotranscobalamin. So suddenly, if you have a result that's within your reference interval, you may have questions because you don't know what proportion of that data point there is holohaptocorin and what proportion is the active form, the holotranscobalamin. So serum B12 has a number of innate limitations. But in addition to the innate limitations that the biomarker has, laboratories include further variations. So we know already that a serum B12 test is only telling us about abundance, not function. We now know that most of what's being measured does not indicate our B12 status. I will tell you later that serum B12 has particular poor utility in some cohorts, including pregnancy. But some of the other challenges are introduced by the laboratories, and this includes using unified reference ranges to interpret their results. We also saw from the figure I showed you earlier that there is poor harmonization for the different serum B12 assays. laboratories must make sure that any bias in the assay they are using is aligned with the reference range that they're using. In addition to the laboratory introduced variation, we have the assay design itself. So we have the poor harmonization. But we also know from EQA schemes that there's evidence of longitudinal variation in assay performance. And we know that these type of assays are vulnerable to some matrix interference effects. For example, in patients with high intrinsic factor antibodies in their circulations in pernicious anemia, we know that this can give falsely high elevated results. We also know that for some patients, we have the formation of B12 and immunoglobulin complexes, which is known as macro B12, which again can cause elevated results and mask a potentially deficient result. So we don't have time today to go through all of these factors, but I thought I might just spend a little moment talking about the importance of using the correct reference interval. And I've referred to already unified reference ranges. So an audit in the UK, for example, shows that nearly all laboratories use a single reference range to interpret serum B12 results regardless of the age of the patient, regardless of the gender of the patient, regardless of the ethnicity of the patient. And does this matter? Well, we think it does. And there's growing evidence in the literature in the last few years how using a reference interval based on mainly a Caucasian population may cause a health inequality for patients from a Black family background. If you use a unified reference interval derived from mainly Caucasian or Asian people to interpret results from a Black family background, there is an increased risk of missing a deficient state. If you are using a unified reference interval mainly derived from adults to interpret results for children, there is an increased risk of missing a B12 deficient state in the children. We don't know yet why children have much higher serum B12 concentrations than adults. So when we put all these limitations together for the serum B12 assay, it's no surprise that the sensitivity for detection of a B12 deficient state is quite poor. Now, the sensitivity of your serum B12 assay will be defined by the cutoff point you use to define deficiency. So I've given you two examples here. Now, this data comes from comparison of performance of the serum B12 assay to methylmalonic acid. Now, there is no gold standard test of B12 status, but methylmalonic acid, there is a consensus view that that is the best performing biomarker. So that is a proxy gold standard marker. So when compared with methylmalonic acid, if you set your reference interval at 170 nanograms per litre, the sensitivity of the serum B12 assay is around 35%, depending on the platform that you're using. This means that if you apply that reference cutoff, you are missing most of the deficient patients. With a cutoff like that, your assay is very specific at 95%, but nonetheless, you are missing most of the deficient patients. Now, we know that we can boost the sensitivity of our serum B12 assay by choosing a higher cutoff. So, for example, if we were to use a cutoff of 340 nanograms per litre, we have the desired effect. The sensitivity leaps to 85%. You're still missing 15 out of every 100 deficient patients, but it's an improved situation on using a lower cutoff. But unfortunately, if you increase your cutoff for deficiency, you have a massive negative impact on the specificity of your assay. Suddenly, the specificity of your assay drops to about 45%. This means that most of the people who you are diagnosing as B12 deficient are actually replete and don't need treatment. So far, I've only given you lots of problems to think about. But actually, it's not so bad for B12, and we have more biomarkers to evaluate the B12 status than we do for any of the other vitamins, and we're going to introduce some of them now. So rather than spend our time looking at complicated biochemistry, I thought we'd simplify this. So we know already from the previous slides and from our general knowledge, I'm sure, that we obtain B12 from food. And we now know that freshly absorbed B12 binds to hollow transcobalamin, and that this is transported to cells and then converted to one of two metabolic forms, methylcobalamin or adenosylcobalamin. We also know that if we decrease our intake of food that contains B12, that within just a few days we will see a decrease in hollow transcobalamin. And then soon afterwards, we'll start to see a decrease in the metabolic forms of B12. So we start to see a decrease in the methylcobalamin and adenosylcobalamin. Now, conveniently for us, when this happens, the cells start to send out biochemical distress signals. So we will start to see an increase in homocysteine and an increase in methylmalonic acid. So we now have 4 B12 status biomarkers. We have serum B12, which we now know reports a total of hollow haptochorin and hollow transcobalamin. We have hollow transcobalamin itself, which is in the laboratory known as active B12. So active B12 and hollow transcobalamin are the same thing. We have homocysteine, which is a functional marker of B12 status. So that's telling us what's going on in the cells. It's telling us what's going on in the cytosol. And we have methylmalonic acid, which is also a functional marker of status and tells us what's going on in the mitochondria. So let's spend some time very quickly reviewing the utility of these 3 other biomarkers of B12 status. And we'll start with active B12, also known as hollow transcobalamin. So it has the theoretical advantage that we are now, rather than measuring total B12, we're now only measuring the active B12, the form of B12 that can be delivered to cells that need it. It has a limitation that, of course, we're only looking at abundance, but head-to-head comparisons of active B12 with serum B12 in the main show marginal superiority for the active B12 test. If we use a cutoff of 30 picomoles per litre, studies tell us we get a sensitivity of around 65% and a specificity of 90%. If we choose a cutoff of 60 picomoles per litre, sensitivity increases, but we still can't break that relationship between assay sensitivity and assay specificity. Active B12 tests are now widely available. So if I was concerned again about my B12 status and I sent an aliquot of my blood to all the laboratories in the United Kingdom that were performing the active B12 test, would I be confident in the diagnosis that I receive? Well, I still wouldn't, because even though this is a superior test, some laboratories are telling me that I might be deficient, others are telling me it's indeterminate, some are normal, and one is telling me that it's high. So your eyes may be drawn to the cluster of green data points in the middle of the chart, the figure here. But actually we do know from the literature that we expect at that concentration of hollow transcobalamin that about a quarter of those aliquots, if we were to measure methylmalonic acid, would tell us that there's an elevation in the concentration of MMA, which is an indication of functional B12 deficiency. And in fact, there's a nice relationship between the concentration of hollow transcobalamin and the likelihood of having an increased MMA. So this leads us to the conclusion that for serum B12 and for active B12, there is an indeterminate range. So below the cutoff, we know there's a deficiency, and above the indeterminate range, we know the patient results are replete. But what do we do about the indeterminate range? Well, actually, some laboratories, including my own since 2012, have adopted a multi-marker approach. And in fact, in the National Institute for Clinical Health and Excellence guidance that was published in the UK this year, this is an approach that guidance recommends. And it's quite simple. You use a first-line biomarker to screen, if you like, the initial B12 status of that patient. And you could use a serum B12 assay or an active B12 assay for that first-line biomarker. You want to choose one of those tests because highly automated assays are available for both of those. And you want to configure it so that it gives you a high sensitivity for B12 deficiency so that you avoid missing deficient patients. You then assign an indeterminate range, and for that range you perform a second-line biomarker. In the example I'm giving you here and in the NICE guidance, they suggest that you use a functional biomarker, homocysteine or MMA, as the second-line test. The intention there is to have a high degree of specificity so that you guard against giving unnecessary treatment to patients who are actually B12 replete. And this approach is entirely satisfactory for most patients, but there are some limitations. So this approach is not suitable in pregnancy or in nitrous oxide exposure. And we'll talk about that towards the end of this talk today. So let's look at homocysteine and methylmalonic acid. Now you'll see a common recurring theme here in that each of the biomarkers has limitations, and that's also true for homocysteine. And I'm highlighting some of the limitations here. One of the main limitations is that folate status has a much bigger impact on homocysteine than B12 status. So this marker is only really useful if you know that the patient you're investigating for B12 deficiency is folate replete. B6 also influences homocysteine concentration, and to a minor extent so does B2. You also need to be aware that homocysteine is increased in a patient with poor renal function, and it also increases with increasing age. One of the main challenges for using homocysteine, especially in a primary healthcare environment, is the pre-analytical instability. It is very important that the red cells are removed from your plasma sample as quickly as possible to prevent artifactual elevations in homocysteine. In much the same way that we spoke about serum B12 earlier, it's also important for homocysteine that you use the correct reference range for the interpretation of results. A commonly used reference interval cutoff is 15 micromoles per litre for adults, but it should be noted that a lower cutoff, preferably around 10 micromoles per litre, is appropriate for children. Males tend to have higher homocysteine concentrations than females by about 2 micromoles per litre, and homocysteine also goes down during pregnancy. The final biomarker we're going to look at today is methylmalonic acid. Methylmalonic acid is perceived to be the best performing biomarker, but it's not imperfect. It has a dependency on renal function. In poor renal function, MMA goes up independent of B12 status. It goes up with advancing age, and there are at least 2 genes that will impact, with a certain SNPs that will impact your methylmalonic acid concentration. Typical cutoffs for methylmalonic acid are 280 nanomoles per litre for patients under 65 years old and 360 nanomoles per litre for patients more than 65-year-olds. The biggest challenge for methylmalonic acid at the moment is that there is no highly automated assay available. It has a requirement on quite expensive equipment, mass spectrometry mainly, and you also need to have a high degree of analytical experience in your workforce to perform the assay. Now, I mentioned earlier two scenarios where the standard first line and second line investigations are not best suited. The first one we're going to touch on very briefly here is in nitrous oxide abuse. Now, nitrous oxide, as I'm sure you're aware, has been used for many years safely for sedation and pain relief in healthcare. But in recent years, it's been frequently abused. In the short term, the person taking nitrous oxide will feel euphoria and uncontrolled laughter. And it's a particularly common drug for young people. And this is because the euphoria and uncontrolled laughter soon wears off, and you may be able to go back to where you live, to your family, for example, and there'll be no obvious evidence that you've been abusing a substance. But prolonged use over the long term will induce memory loss, incontinence, depression, psychosis, and more. Now, the reason that nitrous oxide causes severe B12 deficiency is that the gas oxidizes the cobalt atom within the structure, and it changes the valence state of the cobalt. In a 3+ state, the cobalt dissociates from methionine synthase. The methionine synthase is no longer able to work properly, and this leads to an increase in homocysteine concentration. The other pathway, the methylmalonyl coenzyme A mutase, is not affected so much, but prolonged exposure will eventually cause degradation of B12 and eventually an increase in methylmalonic acid. So if you were to perform all 4 biomarkers in a patient that's been abusing nitrous oxide, you would see a high elevated homocysteine concentration, but the other biomarkers may be normal. So if you were to be performing a serum B12 test, for example, you wouldn't be necessarily picking up that the patient is deficient. In the picture here, I'm showing you an example of some of the canisters you may see disposed in neighborhoods. This is evidence that people are using nitrous oxide. However, in recent years, people are now using even larger canisters, so it's a growing problem. I also mentioned pregnancy as another case for extra consideration. And the recommended biomarker in pregnancy is active B12 as the initial test. And this is because serum B12 concentrations drop during pregnancy, even when there is no B12 deficiency. And this is because there's a decrease in the synthesis of the haptochorin and hemodilution. The hemodilution and hormonal changes also impact on homocysteine and methylmalonic acid. So if you are investigating B12 status in pregnancy, it's recommended that you perform the active B12 test. And then even if the B12 test comes back in your indeterminate range, it is better to treat the patient rather than wait for a second-line test. So in summary, single B12 biomarker approaches have limitations. Regardless of the biomarker you choose to use, optimize how you deliver that test. Make sure you are using the correct reference interval, for example. Remember, serum B12 and active B12 are telling you about the abundance of the vitamin. This may not directly reflect functional status at the tissue level. You can mitigate some of the performance limitations of a biomarker by using more than one. But whatever approach you use, proceed with caution. There is no gold standard biomarker for B12 status. And even if you use a good biomarker, if you deliver it poorly, that will have poor outcomes for the patients. Thank you.
Thank you for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located in the lower left corner of your screen, and we'll answer as many of your questions as we have time for. Let's go ahead and get started here. Our first question asks, what would be an ideal diagnostic pathway for assessing if a patient was B12 deficient?
Okay, thank you for that question. Actually, I would think before recommending a pathway, I think there's a couple of things to remember. And the first thing that each patient is an individual, so that the approach you take needs to be informed by the patient. So you need to listen to the patient in the first instance. The second important point is that patients with B12 deficiency often present in primary care at the beginning of their journey. So it's really important that whichever healthcare provider is seeing that patient, they must be familiar with the signs and symptoms of B12 deficiency. And this is because the signs and symptoms are often quite vague, and actually there's a lot of overlap with other conditions, so that needs to be considered as well. But when it comes to performing the biomarkers, the main thing I'd like to emphasize today around the ideal pathway is that whoever's ordering the test and whoever is interpreting the results needs to know the limitations of that test and the utility of the result and the comments that are coming back. So whether you use serum B12 or active B12, are you familiar with the limitations of those tests? Ideally, in a pathway, you should be able to get to a diagnosis within a single blood test, rather than people coming back from multiple consultations. So make sure the biomarkers you need to perform are done on that single first sample. It saves healthcare resource, and it's a better experience and better outcome, I hope, for the patient. If you get an indeterminate result from your frontline test, your serum B12 or active B12, then it's very worthwhile considering do a second line test as homocysteine or methylmalonic acid. So in answer to your question, I would say I would recommend, where required, a multi-biomarker approach. Preferably in my laboratory, we use active B12, and the second line test for indeterminate active B12 results is methylmalonic acid.
Excellent, thank you. All right, our next question here asks, should active B12 or holo-TC testing being preferred to total B12 testing, i.e. should total B12 testing be substituted by active B12 at all?
So I think in the literature, the majority of the studies that have compared the performance of serum B12 with active B12 have demonstrated moderate superiority for the active B12 test. I think any algorithm you use to diagnose vitamin status, and in this case vitamin B12 status, is only as good as the weakest part of that algorithm. So my suggestion is that you would use active B12, holotranscobalamin, if it's available to you. It is widely available now. A couple of considerations there is that if this is a new test to you and to your users, you need to think about how you educate your users about how to interpret those results. And of course, the other factor to think about is the cost of that test.
Okay, wonderful. Thank you. That is all of the time that we have for today for questions. I want to thank you for your time and your important research. And we would also like to thank LabRoots and our sponsor, Abbott, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.